Okay, I'm Dr. Petita, and I've been tasked to lecture on health and wellness, models of disease causation, and natural history of disease. These are our objectives. Okay, a disease is a particular abnormal condition that negatively affects the structure or function of all or part of an organism and that is not due to any immediate external injury. Trauma is when it's due to an immediate external injury. Okay. So the WHO defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. This definition has its criticisms. First, that it's overly idealistic, because remember, the definition is a state of complete physical, mental, and social well-being, and there's no person who is in a state of complete, total physical, mental, and social well-being. Why? Because syempre, people have their problems, people have their issues, and in their day to day, this is in a constant state of flux. Secondly, this view of health is said to be static because it defines health as a state. So, your health today will be different from your health tomorrow when you have a cold. It will be different from your health on Friday when you have a headache. And it will be again be different from your health next week when you have been cramming and having a hard time sleeping because of all of the unit exams that you have to take. Okay, and it denies the fact that health is a dynamic process that requires constant effort to maintain. So health is in a constant state of flux, and we have to exert effort in order to maintain it. We have to do our exercise. We need to eat right. We need to sleep 6 to 8 hours a day. We have to see our doctor. We have to avoid smoking. We have to avoid drinking alcohol, etc. There are so many things that we have to do in order to keep our bodies healthy. So it's not just a state that we live through, but it's a process that we need to maintain. Okay. So, alternative definitions of health are that health is a successful adaptation. So, Dubos in 1960 said that the states of health or disease are the expressions of the success or failure experienced by the organism in its efforts to respond adaptively to environmental changes. So, when we talk about environmental challenges, we're talking about stress. And stress denotes any response of an organism to demands, whether biologic, psychologic, or social. There are two types of stress: stressors that are helpful or eustress, like exercise, which results in cardiovascular fitness. And there are also stressors that are harmful or distress, like smoking, which results in the accumulation of carcinogens in the body, eventually leading to cancer and death. Allostatic load is the total amount of stress that a person is going through. It's defined as the ongoing level of demand for adaptation to stressors on an individual. The second alternative definition is health as satisfactory functioning. So Breslow in 1999 said that both the current state of a human organism's equilibrium with the environment, often called health status, and the potential to maintain that balance. And Dubos said that clearly health and disease cannot be defined merely in terms of anatomical, physiological, or mental attributes. The real measure is the ability of the individual to function in a manner acceptable to himself and to the group of which he is a part. So, why is health satisfactory functioning? It's because a person will not necessarily see a doctor just because he or she has symptoms or just because he or she is diagnosed with a particular condition. For example, a person with COPD may not necessarily follow up with their doctor because they're feeling fine and they're able to do activities of daily living and they're able to do the things that they want to do satisfactorily. Okay? So we have three definitions of health. The first is the WHO definition. The second, we have health as successful adaptation. And the third is health as satisfactory functioning. Okay. Moving on to models of disease causation. So when we talk about models of disease causation, this is how we visualize disease causation so that we can better understand it and that we can better communicate how diseases are caused. So the easiest one is web of causation. So as the name suggests, it's a web showing the pathway between risk factors and disease. So factor A leads to factor D, leads to factor C, which in turn leads to X disease. The arrow shows the direction of the relationship. In this example, which is for hypertension and cardiovascular disease, stress leads to poor diet, hormonal imbalance, and smoking, all of which are contributory to heart disease, stroke, and hypertensive disease. So the arrows show the pathway. This is particularly useful for illnesses that are multifactorial or that have complex relationships. So as you can see here, stress is contributory to poor diet, it's contributory to smoking, and it's contributory to hormonal imbalance. Likewise, obesity is caused by heredity, physical activity, diet, and hormonal imbalance. And all of these things lead to the end pathway of stroke, hypertensive disease, and heart disease. Okay. Similarly, for dengue, you can have more complex pathways. Okay. So this part is for the agent, the host, and the environment host interface. Okay. The arrows point to the direction of the relationship, but it doesn't express the magnitude of that relationship or by how much one particular factor contributes to another. Okay. The epidemiological triad or lever. So as the name suggests, this is just a triangle or a or a lever. So this is another model of disease causation, an external agent, a susceptible host, and the environment that brings them together. The agent, host, and environment constitutes the apex of the triangle. And for the epidemiologic triad, you have the agent and the host on either side of the seesaw, and the environment as the fulcrum that brings them together. Okay. The agent, this is the agent and agent related factors. This is the environment and environment related factors. And this is the host and host related factors. The theory here is if you're able to break the interface between agent and host, agent and environment, and host and environment, you will be able to prevent the onset of illness. And these are the interventions for each of the interfaces. Take note that this is in by no means an exhaustive list. There are many other agent-related factors, environmental-related factors, host-related factors, and there are many more interventions that break the interface between them. So by way of so for the epidemiological lever, this is how we interpret it. So agent, host, and the environment in which they interact. So in this example, the agent is heavier than the host. So this would show an increase in a change actually in the system such that the agent is now has a greater ability to infect the host. In this example, the host is heavier. So there's been a change which results in increased susceptibility of the host. In this example, the fulcrum has shifted to the agent, and the agent is heavier. So there was a change in the environment which favors the infectivity of the agent. And here the fulcrum moves towards the host. So therefore, there is a change in the environment which favors host susceptibility. Okay, by way of example, this is leptospirosis. Okay, this is the agent, leptospirosis. Okay, the host is the human being, and the portal of entry is the open wound, and the environment in which they meet is floodwaters. Okay, so in order to intervene in the agent host interface, you can do your chemoprophylaxis with doxycycline. So this will prevent the agent and the host from the agent from infecting the host to um, to intervene in the host environment interface, wearing boots so that the host's feet are no longer exposed to the floodwaters. And finally, the agent environment interface. The intervention there is proper sewerage or elimination of the reservoir so that there are fewer rats where the leptospira can grow, and therefore there will be fewer leptospira that can enter the environment and infect the host. Okay? All right, agent. An agent is a factor, such as a microorganism, chemical substance, or form of radiation, whose presence, excessive presence, or relative absence in the case of deficiency disease is essential for the occurrence of a disease. This was originally referred to as an infectious microorganism or pathogen. Examples of non-infectious agents are mechanical forces, which result in carpal tunnel, and fatty food, which results in the formation of your atherosclerosis. So an agent is any factor which is essential to cause disease. It must be present to cause disease or absent in the case of deficiency syndromes. Okay, examples of agent, your viruses, your leptospira, this is your ascaris or your parasitic worms, tuberculosis, your mycobacteria, and this is your bacillus. Reservoir. The reservoir of an infectious agent is the habitat in which the agent normally lives, grows, and multiplies. It may or it may not be the source from which the agent is transferred to the host, humans, animals, and the environment. So the example that we give is Clostridium botulinum, which exists in the soil. Humans typically do not get botulism from playing in the soil or from being exposed to soil that contains Clostridium. Typically, we get it when we eat canned goods that have not been properly sterilized. Okay, so it typically lives and grows. Clostridium botulinum typically lives and grows in the soil. Okay, so examples of reservoir: rabies typically lives and grows in bats. Mosquitoes, there are a lot of infectious diseases that typically live and grow in mosquitoes, including dengue, etc. Okay, another example, anthrax. Anthrax typically grows in the soil, and people usually get infected when they are exposed to livestock, like cattle and sheep. This is wood sorter's disease, or anthrax. Okay, so vehicle. Vehicle is the mode of transmission of an infectious agent from its reservoir to a susceptible host. It can be person to person, foodborne, vector-borne, or waterborne. A vector is any living creature carrier that transports an infectious agent from an infected individual or its wastes to a susceptible individual or its food or immediate surroundings. The agent may or may not pass through a developmental cycle within the vector. The host refers to the human who can get the disease. Risk factors are intrinsic to the host, which influence an individual's exposure, response, or susceptibility to an agent. This would include genetics, hygiene, sexual practices, and nutrition. So, for example, would be lifestyles like exercise or lack thereof, screen time, diet, healthy and not so healthy, comorbidities, hygiene, and genetics. These are all host-related factors. So environment is the the environmental factors are extrinsic factors that affect the agent and the opportunity for exposure, like air quality, weather, sanitation, health services, running water, and sewage. So remember, the agent, the host, and the environment that brings them together. That's your epidemiological triad. So ito, floodwaters, sewerage systems, which we don't have a lot of here in the Philippines, landfills, and of course, a healthy living environment. Okay, the chain of infection starts with a pathogen, which grows and multiplies in the reservoir. It leaves its host through the portal of exit and enters the environment. It crosses over through the mode of transmission, enters the portal of entry of a susceptible host, and the cycle begins anew. So pathogen, multiplies in a reservoir. It leaves its host through the portal of exit, enters the susceptible host through the portal of entry via a mode of transmission, and the cycle begins. Okay. So ito yung agent. It dips in the reservoir. It's transmitted through a vehicle, either vector-borne, direct contact, droplet-borne, water-borne, airborne, etc. Enters a portal of entry of a susceptible host. It grows and multiplies inside of its host, leaves the host through the portal of exit, re-enters the reservoir, and then the cycle begins anew. Okay. Rothman's causal bias. The agent host environment model did not work well for many non-infectious diseases, and this particular model of disease causation is useful when causation is multifactorial or complex. So how are Rothman's causal pies interpreted? So an individual factor that contributes to causing the disease is shown as a piece of a pie. The component causes are individual factors. Sufficient cause is a completed pie. It represents a causal pathway. And the necessary cause is a component that appears in every pie. So for this example, you have 5 causal pathways or sufficient cause. And the letter B represents for this particular sufficient cause, the letter or pathway, the letter B represents a factor, a causative factor. The size of the pie shows by how much it contributes to a particular disease. Okay. And take note that B is present in all 5 pathways, and therefore we say that it is a necessary cause because it exists in all 5 pathways. So by way of example, death from a head-on car collision, you have 3 pathways which result in death from a head-on car collision. And what's common in all 3 pathways is that a car hits another vehicle. Practical application of this is that if you were to employ some kind of health intervention to prevent death from a head-on car collision, you will focus on preventing a car hitting another car in this example because it is a necessary pathway. It is a necessary it's a necessary cause which exists in all 3 pathways. So therefore, dun ka magfo-focus ng efforts mo. Okay. All right. So we explained 4 models of disease causation. The first is your web of causation, followed by your epidemiological triad, your leader, and your chain of infection, and your Rothman's causal bias. So there are 4 models of disease causation in this lecture. Natural history of disease. The natural history of disease is the progression of a disease process in an individual over time in the absence of treatment. Okay, there are 4 stages in the natural history of progression. The stage of susceptibility, wherein you have a healthy host. The stage of subclinical disease begins from the time of exposure until onset of symptoms. During this time, the host is exposed to the agent, and pathological changes begin to occur in the body. These changes accumulate until finally the patient presents with symptoms, and this heralds the beginning of the stage of clinical disease. Usually, illnesses are diagnosed at the stage of clinical disease kasi syempre, may nararamdaman yung pasyente. Dito lang siya may nararamdaman. Finally, a disease will end with one of 3 outcomes: recovery, disability morbidity, or death. Okay, the stage of susceptibility. The disease has not begun yet. This involves the accumulation of risk factors that facilitate entry of the agent into the host in a favorable environment. So examples of host-related factors would include previous illness, lifestyle, hygiene, precautions, and safety measures. Exposure begins with exposure of the host to a risk factor or causative agent. For example, with cancer, exposure begins with accumulation of a risk factor, like smoking. Or COVID-19, which begins with exposure to the COVID-19 through droplet contact. Portal of entry is the site through which the microorganism enters the susceptible host and causes disease or infection. And a portal of exit is the site from which microorganisms leave the host to enter another host and cause disease or infection. The stage of subclinical disease begins from the time of exposure until onset of disease symptoms. This is when pathological changes begin to occur in the body. It is largely asymptomatic. For infectious diseases, this is referred to as the incubation period. And for chronic illnesses, this is referred to as the latency stage. Carriers are patients who have subclinical disease but are infectious. Clinical disease begins with the onset of symptoms. This is the time when most illnesses are diagnosed, and this is the time when most diagnostics are done. This is also the time when patients start to consult with their doctors kasi it's at this point na may nararamdaman sila. The spectrum of disease can range from mild to severe to even fatal. And of course, the last stage is the outcome. So ultimately, all disease processes end in one of three outcomes: disability, morbidity, recovery, or death. Infectivity is defined as the proportion of exposed persons who become infected. Pathogenicity is the proportion of infected persons who develop clinically apparent disease. And virulence is the proportion of clinically apparent cases that are severe or fatal. So describing the natural history of dengue, we have a host during the stage of susceptibility. Okay, we have a host minding his own business who's walking around, probably without any insect repellent, who becomes bitten by an Aedes aegypti. And at this point, he is exposed to the dengue virus by the bite of the mosquito. The, the dengue virus enters the patient and it multiplies and it incubates for 4 to 7 days. So the 4 to 7 day incubation period corresponds to the stage of subclinical disease. At the end of the incubation period, the patient will begin to have fever, dehydration, hematocrit, and viremia. And at this point, this is when the clinical disease starts. Okay? The patient will have fever for 3 days. Then the fever will begin to defervesce. And this is when the critical phase begins at the point of defervescence. Because that is when the patient will start to have the bleeding diathesis, the Herman's rash, and this is when the patients may go into shock and organ impairment. Okay. At the end of the critical phase, on the 6th day, there will be this is the recovery phase. This is when the extravasated fluid is reabsorbed, the platelet starts to increase, and the IgG, IgM antibodies start to increase as well. Okay. It's in the critical phase that your patients may die because this is when they suffer hemorrhagic shock, when they go into bleeding, etc., etc. If they survive this, then they recover. Right. Okay, so again, there are 4 stages in the natural history of disease: susceptibility, subclinical disease, clinical disease, and your outcomes. Okay, levels of prevention. There are 5 levels of prevention, and they correspond to the natural history of disease. So primordial and primary targets the stage of susceptibility. Secondary, subclinical disease. Tertiary and targets the clinical disease and the outcome stage. And quaternary is subclinical onwards. Okay. So primordial, risk factor reduction targeted towards an entire population through a focus on social and environmental conditions, laws, and national policies. This is often aimed at children to decrease as much as risk exposure as possible, and improving access to an urban environment to safe sidewalks to promote physical activity. This in turn decreases risk factors for obesity, cardiovascular disease, and type 2 diabetes as examples. So primordial level of prevention, this targets entire populations. Your patients at this level of prevention are all healthy and they have not yet been exposed to the disease. So examples of primordial prevention, government policy, increasing taxes on cigarettes, decreasing advertisement of tobacco, built environment, access to safe walking paths, access to stores with healthy food. So these are interventions that are aimed towards entire populations. Okay. So built environment, sidewalks, bike lanes. This is the graphic health warning law. Executive Order number 26, which prohibits smoking in public places, and the sin tax on sugar, which is aimed at reducing consumption of soft drinks. Okay, primary prevention. These are measures that are aimed at susceptible individuals, and the purpose of primary prevention is to prevent the disease from ever occurring. The target are healthy individuals. These are activities that limit risk exposures or increase the immunity of individuals at risk to prevent the disease from progressing in a susceptible individual to subclinical disease. And an example of primary prevention is vaccination. Other examples of primary prevention would be immunization, tobacco cessation programs, needle exchange programs, and micronutrient supplementation programs. So again, for primary prevention, you are targeting healthy individuals without disease who have not yet been exposed. Okay, so vitamin A supplementation, vaccination, needle exchange programs, and the distribution of condoms as prevention for HIV and AIDS. Secondary prevention involves early disease detection. The target are healthy appearing individuals with subclinical disease. So these are patients who have already been exposed. They have, but they have not yet been diagnosed. They still have subclinical disease. They are asymptomatic. And secondary prevention primarily involves screening. So example, a pap smear is a form of secondary prevention aimed to diagnose cervical cancer in its subclinical state before progression. So examples of secondary prevention, lahat ng screening tests mo, pap smear for early detection of cervical cancer, mammography for early detection of breast cancer, colonoscopy for early detection of colon cancer, and of course your blood pressure screening. So again, this is your cervical cancer screening. So you have an speculum inserted into the vagina and a pledget to get swabs of the cervical mucosa. So this is the cervical mucosa. This is the colonoscopy and blood tests. Tertiary targets both the clinical and outcome stages of a disease. It's implemented in symptomatic patients and aims to reduce the severity of the disease as well as any associated sequelae. And it aims to reduce the effects of the disease once established in an individual. So treatment and rehabilitation are both components of tertiary prevention. Okay, so because you are trying to reduce the severity of the disease and any associated sequelae. So treatment and rehabilitation. Yeah. Examples of tertiary prevention, occupational physical therapy in burn patients, cardiac rehab in post-MI, and diabetic foot care. So this is your Dakin solution for diabetic foot care, rehab, the use of orthotics. Quaternary is actions taken to identify patients at risk of over-medicalization and to protect him from new medical invasion and to suggest to him interventions which are ethically acceptable. So these are actions taken to protect individuals from medical interventions that are more likely to cause harm than good. So the target is individuals with the illness but not the disease. So examples of conditions susceptible to overtreatment would be radiological incidentalomas, the use of antiarrhythmic drugs after MI that reduce arrhythmias but increase mortality, the use of hormone replacement therapy in postmenopausal women, which has apparently led to an increased number of breast cancers, stroke, and thromboembolic events. It was also a failure in reducing CV mortality. Medically unexplained symptoms, functional disorders, and bodily distress syndrome. None of the last three requires medical treatment. So the idea of quaternary prevention is to prevent over-medicalization or over-treatment, over-diagnosis. Okay, and we can do that through the use of guidelines, both HMO and clinical practice guidelines established by the societies, through judicious use of diagnostic tests, and through litigation and the enactment of laws to protect patients. Okay. So again, we have 5 levels of prevention. Primordial, which primarily uh, targets healthy individuals. Sorry, not healthy individuals, healthy populations. You have primary prevention, which targets healthy individuals, and the purpose is to prevent the disease from ever occurring. You have secondary prevention, which targets healthy individuals in the subclinical stage, and this is primarily your screening tests. You have your tertiary prevention, which targets both the clinical and outcome stages of a disease, involving both, and it involves treatment and rehabilitation. And your quaternary, which is to avoid over medicalization, the judicious use of your diagnostics, the judicious use application of your therapeutics, so that your patients to prevent your patients from coming to harm. Okay. All right. That's all. Thank you.